As alluded to by Dr. Hahn, we've seen a virtual epidemic of fatty liver disease in the United States. To provide us an update on the evaluation and management of these patients, it's a pleasure to welcome to the podium Dr. Francisco Durazo. Dr. Durazo is a professor of medicine at UCLA, and he's the director of the Dumont Liver Transplant Center. Dr. Durazo.
Good morning, everybody. Glad to be here. I would like to thank the organizers of this meeting for inviting me to be here in Vegas. You know, remember what happens in Vegas stays in Vegas. So I'm going to talk about fatty liver. Probably you've noticed it's now a public health problem. And just to start with, the first term that was coined was NASH, actually non-alcoholic steatohepatitis. And this was from Dr. Ludwig in 1980. He had a group of 25 patients that had alcoholic liver disease, but they didn't drink. He ruled out other causes of liver disease, and he noticed that most of them were obese. Quite a bit of them had diabetes, hypercholesterolemia, 90% had a palpable liver, 25% had stigmata of chronic liver disease, and their liver biopsies showed steatosis, ballooning of the hepatocytes, Mallory bodies, and sinusoidal fibrosis, and some had cirrhosis. So he coined this non-alcoholic steatohepatitis because patients didn't drink. So it has been a while since the term was coined, and now we know that NASH is a part of a spectrum of steatotic liver disorders known as NAFLD. NAFLD is a spectrum that goes from simple fat deposition or non-alcoholic fatty liver disease to fat with inflammation, which is NASH, a more aggressive type of disease. Now it's a new term in lipotoxic liver disease, and this to cirrhosis, and then the development of hepatocellular carcinoma. Fat deposition is going to depend in a dysregulation of the lipid metabolism in the setting of insulin resistance, and the advancement from fat to fat with inflammation is going to depend on the development of an inflammatory response against one or more neoantigens within the lipid-laden hepatocytes. It is the most common liver disorder in the world right now, and most common cause of abnormal liver tests in the United States, and its prevalence worldwide goes from 6.3 to 33%, depending which group you study. NASH 5%, but in the United States it goes up to 46% in certain groups, and NASH up to 12.2%. It usually appears between the 4th and 6th decade of life, and it's an independent risk factor for coronary artery disease. It is important also to have in mind that it increases the risk for the development of hepatocellular carcinoma, and we know that there is a genetic predisposition. This is a single nucleotide polymorphism, the PNPLA3, that it has been shown that patients with fatty liver that have this polymorphism are going to have a very aggressive type of fatty liver, more fibrosis, cirrhosis, and very high risk for the development of hepatocellular carcinoma. And actually, this polymorphism is quite prevalent among the Hispanic populations, among the groups that have most fatty liver, as we are going to see here. There is some gender and racial disparities. We see that fatty liver is much more common in Hispanics. Same males, the same as females, you see up to 45%. In Caucasians, it varies. Male Caucasians are going to have it more than females, And in African Americans, with the ones that have the highest BMIs, they have the lowest prevalence of fatty liver. Next slide, please. And now we know that fatty liver has joined the components of the metabolic syndrome, together with insulin resistance or diabetes mellitus, hyperlipidemia, hypertension, and truncal obesity, and NAFLD. So the more components of the metabolic syndrome in any given patient, the more advanced liver disease, as we will see here. This study by Dr. Dixon shows that this is the percentage of NASH, and we see that patients without any components of the metabolic syndrome have a very low prevalence of NASH, but as they develop hypertension, for example, the risk for NASH goes up, diabetes goes higher, and if they have both, you can see they have a high prevalence of non-alcoholic steatohepatitis. The metabolic syndrome seems to be a systemic disease, and it's right now what it's called a chronic inflammatory state. We also know that increase or excess energy supply that outweighs the metabolic needs is going to cause metabolites derived from triglycerides. And this is going to trigger insulin resistance, inflammation, cellular dysfunction, and apoptosis. This is through the increased synthesis of these cytokines, TNF-alpha, NF-kappa B, AP1, interleukin-1 beta, interleukin-N18. And we also know that excess of calories, caloric excess, is going to disrupt the intestinal barrier, leaking endotoxins and lipopolysaccharides into the circulation. So all this is going to cause the chronic inflammatory state of the metabolic syndrome, and as well as fatty liver, now called lipotoxic liver disease. The main abnormality in fatty liver is insulin resistance. So if you have a patient with fatty liver, it's like a flag saying, yay, we have insulin resistance in this patient. And the main problem is inappropriate suppression of lipolysis by insulin. So we are going to have increased lipolysis, so this is going to have increased free fatty acids in the circulation. When free fatty acids enter the liver, they are going to increase the glucose load. On the other side, increased free fatty acids are going to decrease the metabolic clearance of glucose by the muscle, and again, more glucose into the circulation. So glucose load is going to increase and increase. The pancreas, on the other hand, it needs to secrete more insulin until the pancreas says, you know, I quit. And then it's when diabetes appears. Fat by itself doesn't seem to be bad for the liver, because not everyone that has fat deposition is going to develop chronic liver disease. So therefore, it must be fat and something else that together with fat that is going to make some people develop NASH and cirrhosis, and others stay just with fatty infiltration without progression of liver disease. This is the two-hit hypothesis, with the most acceptable one that states that there is an imbalance between oxidants and antioxidants. There is increased radical oxygen species with diminished antioxidants, and this due to uncoupled oxidation and phosphorylation, cytochrome P450 activation, and also peroxisomal fatty acid oxidation. So this imbalance in the presence of TNF-alpha and the other cytokines that I mentioned before are going to increase oxidative stress within the hepatocytes. This, in the presence of fat, are going to trigger what we call non-alcoholic steatohepatitis. Most of the patients are asymptomatic. The typical patient is the one that has abdominal pain, goes to emergency room, has an abdominal ultrasound, and the abdominal ultrasound shows fatty liver. Or some patients applied for life insurance. They are denied because of abnormal liver tests. Some patients complain of vague right upper quadrant pain. We don't know why. We think it's probably fat distending the liver capsule. They complain of having like a bowling ball up here. Quite a bit of them, and almost all of them, are going to have hepatomegaly. And the typical liver test abnormalities are going to be elevated ALT and AST. ALT is going to be higher than AST. If the AST is higher than ALT, suspect alcohol. And patients that have already cirrhosis are going to have the stigmata of chronic liver disease. And interestingly, patients with NAFLD or fatty liver are also going to have elevated ferritins and positive antinuclear and smooth muscle antibodies. The diagnosis is very simple, like the name says, non-alcoholic fatty liver. So first step, we need to demonstrate the presence of fatty infiltration of the liver. This is very simple. It can be done with an imaging study such as ultrasound or CT scan. What sometimes it's troublesome is to establish the non-alcoholic nature of the disease. So how much is non-alcoholic and how much is alcoholic? How much alcohol is going to harm the liver, and how much alcohol is safe? Well, the numbers that we have right now are if a person, a male, drinks more than 30 grams a day, and for females in more than 20 grams of alcohol a day, that is supposed to be harmful for the liver. However, all these numbers are very arbitrary because this has been very difficult to study. For example, we have, let's say, a medical student. He probably drinks 2 bottles of tequila on the weekend, but doesn't drink from Monday to Friday because he has to study. Or, we take a lawyer, he drinks probably 3-4 drinks every day, but doesn't drink on the Sundays, or because he has to be with the family. So, it's all these different drinking patterns can make it very difficult to establish. However, most of the time, we are able to establish the non-alcoholic nature of the disease. And also look at ALT-AST ratio. That is also very helpful. Next slide, please. This is an example of an ultrasound of the liver showing a fatty liver, hyper-echoic liver. And this is a more objective, a CT scan. You can see this is the liver. This is the stomach with contrast. This is the spleen. This is the spine. And the liver should be the same color as the spleen, but you can tell that all this dark coloration is due to fat deposition. The gold standard is for the diagnosis is a liver biopsy. And only with a liver biopsy we can diagnose NASH, not even with imaging or blood test, only with a liver biopsy. And here you have an example. This is a patient with a simple hepatic steatosis. You can see hepatocytes are very normal, beautiful hepatocytes, just fat droplets within the cells, but no infiltrate, and looks pretty good. And this is an example of NASH. We can see lymphocytic infiltrate, ballooning of the hepatocytes with Mallory bodies, and you can start to notice here sinusoidal fibrosis, or what we call chicken wire fibrosis. So should we do a liver biopsy in all the patients with fatty liver? I don't think so. We don't have enough doctors to do so many biopsies. I don't think we have enough liver biopsy needles or enough pathologists that we would be all day doing biopsies and reading slides. So who should we biopsy? Which patients with fatty liver should we biopsy? The ones in which we suspect advanced disease. And who are they? As I mentioned, the ones that have metabolic syndrome, hypertension, diabetes, hypercholesterolemia. There is a NAFLD fibrosis course, very simple to get online, and it includes just age of the patient and very simple clinical information. And this can give you a guideline on how much fibrosis does the patient have. This has been validated. And if the score is more than 0.6, it's suggestive of the presence of significant fibrosis. Another indication for biopsy is if you are not sure of the diagnosis. Let's say you have a patient with fatty liver, but he looks pretty good, like a movie star, no diabetes, no hypertension, no hypersterolism, and you say, well, something is wrong with this picture, this young man with fatty liver. So if you doubt and if you suspect other diagnosis, then a liver biopsy is indicated. And right now, also with all the bariatric surgery going on, we recommend patients undergoing bariatric surgery, just ask the surgeon, while you just with a needle get a liver biopsy, it doesn't take more than a minute. Or also during cholecystectomy, we recommend if you are going to have surgery, well, why don't you get a liver biopsy? It's going to be very helpful. Patients with a fatty liver are at risk for hepatocellular carcinoma. This is a study from Dr. El Serag, a pretty painful study. He included over 320,000 patients. This is from the VA. And he studied patients that were discharged from the hospital and followed them for 14 years, and saw that patients that had diabetes had more than twice the risk for the development of hepatocellular carcinoma. And this seems to be on the basis of cryptogenic cirrhosis or NASH cirrhosis. We know that probably at least 80% of the patients with cryptogenic cirrhosis have really NASH cirrhosis. The problem is that NASH cirrhosis is very difficult to diagnose because when you do the biopsy, when patient develops cirrhosis, all the fat is gone, there is only fibrotic tissue, so you do biopsy and it shows cirrhosis, all the features of NASH are gone. What's more scary also that over the last 5 years, we've been seeing more and more reports, case series of patients with fatty liver and hepatocellular carcinoma without cirrhosis. You know that the general rule is cirrhosis and then hepatocellular carcinoma, except in patients with hepatitis B. But now that we are seeing that patients with a fatty liver can develop hepatocellular carcinoma without going through cirrhosis, as you see in this patient. This patient has a very nice, normal-looking CT scan, normal liver, normal spleen, no collaterals, and a lesion in the right lobe of the liver. Biopsy of this lesion came up as hepatocellular carcinoma, and the underlying parenchyma showed no cirrhosis, only minimal fibrosis. So this is worrisome. The natural history has been difficult to study from NAFLD because you need a long time to study and to follow up these patients. So it has been difficult due to the lack of prospective, longitudinal, long-term studies with histologic follow-up. However, this information is from the best 5 published studies, and it shows that in patients with a fatty liver, histologic stability is going to be in the majority of them, 59%. Actually, some of them are going to have some histologic improvement, but what is worrisome is that 28% have the chance of progressing to cirrhosis of the liver. Next slide, please. So the management, well, the management, I think, important to know if the patient has NASH or simple steatosis or not. Number one, we have to pay attention to the components of the metabolic syndrome. A patient with fatty liver treat the metabolic syndrome, obesity, hyperlipidemia, insulin resistance, diabetes, etc. If the patient has simple fatty liver, no liver-specific treatments. Patients that have simple steatosis without NASH, they have very, very low chances of progressing towards NASH, very low. So those are, don't need any liver-specific treatment. The ones that need treatments aimed at improving liver disease are the patients that have NASH. So which treatments do we have? Well, there have been a lot of different treatments, a lot of attempts to trying to treat NASH using all different modalities. For example, weight loss and lifestyle modification, weight loss with medications, insulin sensitizing agents, metformin, the glitazones, antioxidants, vitamin E, betaine, N-acetylcysteine, lipid-lowering agents, clofibrate, atorvastatin, gemfibrozil, fatty acids, anti-TNF, pentoxifylline, intestinal flora modifier, Chinese herbal medicine, bariatric surgery, you name it. There are a lot of studies. However, the problem is that most of the studies are poor quality. They are not prospective, not controlled. Most of them include a small number of patients. So really, they do not follow basic design requirements for clinical trials. And disappointing results really do not lead to a clearer recommendation to start to treat patients with NASH. And as I mentioned before, given the very slow progressive nature of NASH, really what these studies are using are surrogate markers of clinical outcome. So let's see what has been done. Let's start with weight loss and lifestyle modification. Initial studies criticize weight loss and lifestyle modification because, yes, they improve ultrasound in the liver, but there are no biopsies. So these two studies did a baseline biopsy, lifestyle modifications, and then a biopsy 1 year later. Here we see these studies, diet, exercise, and behavioral modifications versus structural education as a control, and they saw significant improvement in steatosis, lobular inflammation, ballooning, NASH activity score, weight reduction through lifestyle intervention. And this other one is 56 patients. They were 4 different regimens. One was standard care, and these were 3 regimens with exercise, moderate exercise with low-fat diet, exercise with fat and low processed carbohydrate, and exercise only, and all these were beneficial. Regardless of any of these intervention, lifestyle modification improved liver histology. No difference between these groups. So we know that diet, lifestyle modification really works. We have a fatty liver clinic, and we've seen very good results. The only problem is that adherence to lifestyle intervention is problematic. For example, we see a patient in clinic, 240 pounds, and say, well, you need to lose weight. And the healthiest way to lose weight, at least just to lose it slowly. So we tell the patient, okay, no problem, you don't need to lose 20 pounds to go to a wedding in 3 weeks, just lose it slowly. 10% in 6 months would be 24 pounds in 6 months, so you only need 1 pound a week, that's all. So we see her in 6 months later and looks like it was the opposite, 1 pound gain a week. So this has been a problem with it really works. If the patient lose weight and exercise, that's the best, and I tell them that's the most beneficial, more than medications, and it's free. It's free, you just need to do it and that's it. But you see, the problem in these trials, for example, only 15 of the patients were able to achieve weight loss, and they used 7% of weight loss. And then, you know, fatigue was a common reason not to exercise. Give me a break. So, you know, so we know, I think, weight loss, dietary changes, and exercise should be recommended to all the patients with NASH, and not only to improve the fatty liver, but also to modify their cardiovascular risks. How about coffee? We know that coffee has been used throughout, and it initially shows some benefit in patients with alcoholic liver disease, it was noticed that patients that drank coffee had less progression towards cirrhosis. And then in hepatitis C, in the HALT-C trial, over 3,000 patients, they noticed that patients that had coffee had less progression towards fibrosis, and now coffee in NASH. And this is a study from 782 adults. This is from the NASH Clinical Research Network. And it showed that coffee consumers that have a low or mild moderate insulin resistance, they have lower odds of advanced fibrosis. So they concluded that coffee intake is inversely associated with advanced fibrosis in patients with mild to moderate insulin resistance. Another study also from San Antonio in the Army also showed that coffee consumption is associated with a significant reduction in the risk of fibrosis among NASH patients. And in these studies, they were used regular coffee, non-decaf, not accepted. And regular coffee, and patients, the ones that showed some improvement, they had to drink at least 2 to 3 cups of coffee a day. How about glitazones? Well, if insulin resistance is present in all these patients, why not use insulin sensitizers? There are 6 trials using pioglitazone and rosiglitazone, and they showed some histologic improvement, not much improvement in fibrosis, but definitely some histologic improvement. So in regards to the thioglitazones and the glitazones, histologic improvement was seen. However, should we use a pioglitazone, for example, in a patient with non-diabetic patient with fatty liver? We know that the big scandal with Avandia and heart disease. We also know that the glitazone can cause weight gain, some bone loss, and there is a risk for bladder cancer. So safety of this medication in non-diabetics is unclear. But I think histologic benefits in patients with diabetes are beneficial. So risk versus benefits, I think these are indicated. You could use the glitazone in diabetic patients with NASH. Just watch their weight. Metformin, another insulin sensitizer. There are also 6 trials done with metformin and unfortunately, it was not very impressive. Liver histology was unchanged in all these trials, but it still can be used in patients just to treat diabetes. It is not recommended to treat NASH per se, but it can be used in patients with NASH to treat diabetes. Vitamin E, vitamin E has been used to treat quite a bit of diseases, gout, rheumatoid arthritis, and trials have been not very good in quality. However, there was a PIVENS trial, prospective randomized double-blind control trial comparing pioglitazone, vitamin E, and placebo, and looks like vitamin E was superior to the other ones. It showed improvement of the aminotransferases, improvement in steatosis, inflammation, ballooning, and resolution of steatohepatitis. There was no much effect on hepatic fibrosis. A concern is that there was an article published in JAMA that showed that patients that took 800 or more international units of vitamin E had an increased overall mortality, and also a recent one that showed patients taking vitamin E had a higher risk for prostate cancer. So, however, in spite of this, the AASLD recommends vitamin E as first-line pharmacotherapy for biopsy-proven NASH. Well, if most of these patients have hyperlipidemia, why not use hyperlipidemia treatment and see if NASH improves with this? The trials were done with the statins, different types of statins. There are 5 trials, and endpoints were a little bit different from each one. And what it showed that they improved liver tests, but they did not improve histology. They also improved cardiovascular outcomes. So therefore, statins are not recommended to treat NASH per se, but patients with NASH can be treated with statins. A common question is, can I give a statin to a patient with fatty liver and abnormal liver tests? Yes, you can. So the benefit outweighs the risk. We now know that the statins are not harmful to the liver on very, very, very few instances. Really, hepatotoxicity from the statins are very, very few cases counted, if you consider how many millions of people take them. So, and actually, the recommendations are do not follow liver tests while giving the statins, unless the patient is symptomatic, of course. So statins can be used in patients with fatty liver, even with abnormal liver tests. Ursodiol has, the old Urso or Actigal has been used. Also, there are several trials, attempts until the last trial from the Mayo Clinic that showed that there was no evidence of efficacy and therefore not recommended for the treatment of NASH. How about Orlistat? Lose weight with Orlistat and see if that helps fatty liver. There was really not much benefit from this and no evidence supporting efficacy, so therefore not recommended for the treatment of NASH. If TNF-alpha is involved in the NASH progression, why not use anti-TNF-alpha medication to try to prevent NASH? Well, there are several trials using pentoxifylline, 4 of them, and again, no evidence of efficacy, so therefore not recommended for the treatment of NASH. the new one, and there was a lot of press and publicity about the obeticholic acid. Obeticholic acid is a FXR receptor agonist. FXR is a part of the family of four families of gene regulators that act in the liver and in GI organs, controlling hundreds, probably thousands of different functions. And obeticholic acid seems to exert its action, one of its effects in fat excretion through bile. So there was a trial called the Flint trial, multi-center trial in over 200 patients. It was 72 weeks with the endpoint was histologic and fibrosis improvement. And by the second interim analysis, they reviewed the biopsy and they decided to terminate the study because there was significant improvement in the patients that were taking obeticholic acid. So it showed that the ones taking obeticholic acid had 45% improvement versus 21% in the placebo. So that looked promising. However, side effects. 30% had of the patients had severe pruritus. Some of them had to stop the medication. And not only that, but obeticholic acid made this metabolic syndrome a little bit worse. Increased the cholesterol, increased the LDL, lowered the HDL, and increased also insulin resistance. Next slide, please. So the lack of pharmacologic therapy, of the lack of the silver bullet to weight loss, look good, and get rid of fatty liver has fueled the demand for weight loss surgery. This is bariatric surgery, which has increased from 1992. This is in probably right now we're up to here on the roof because everybody's having bariatric surgery, as you can see. Right now, bariatric surgery has restrictive procedures and malabsorptive procedures. The malabsorptive ones are the classic iliac bypass. Those are known to cause liver disease. So the ones that are used right now are the restrictive procedures. The most common one is the Roux-en-Y gastric bypass. Some are still using the lap band. So you'll see amazing results with bariatric surgery compared with pharmacologic therapy. Weight loss is very common. Histologic improvement in 91% of the patients. Also improvement in liver tests, and more important, improvement of the metabolic syndrome. In another study with in patients undergoing Roux-en-Y gastric bypass, again, BMI went down, metabolic syndrome components subsided, or some of them disappeared, improvement in the liver tests, and most histologic improvement, 89%. This is really pretty good results. This is a meta-analysis of 15 studies on bariatric surgery and NASH, and again, showed that improvement of resolution of steatosis in 91%, in steatohepatitis 81%, fibrosis improvement 65%, and even complete resolution of NASH was seen in 69%. So these are really excellent results. So steatosis, steatohepatitis, fibrosis improve or completely resolve in a majority of patients after bariatric surgery. So should we do surgery in all the fatty liver patients? I don't think so. So you saw how many attempts, how many treatments, how many trials, and looks, we are continue to work and work, but we are not going any place. We are just staying in the same place. So how do we treat? I don't know. So I'm going to tell you what do I do or what do I recommend in a patient with fatty liver. Number one, regular exercise, a well-balanced diet, and weight control. Those are the most beneficial things for the patients if they can do it. Of course, type diabetes of the control of diabetes and the other components of the metabolic syndrome, such as hyperlipidemia. Avoid alcohol. Alcohol is going to contribute to fat deposition. Coffee, if there is no contraindications, I tell them, well, take a couple, go to Starbucks or, once a day, 2 or 3 cups a day in the morning so you can sleep at night. Very important, fructose intake. This is the problem if our obesity epidemic in the United States. Fructose is all over, in all the drinks, in all the food, in any sugar, they include fructose. And fructose has a very high caloric index, and actually some of it's turned into triglycerides. Vitamin E in patients that have biopsy-proven NASH, that have significant NASH, they might benefit from vitamin E, but you have to weigh the risks of prostate cancer. You could probably consider vitamin E, and even some will consider a biopsy 1 year later, and just to see if the patient is improving. If the patient is improving on vitamin E, you could leave it there. If patient is not improving, you could just discontinue it. Pioglitazone in diabetic patients with biopsy-proven NASH. We saw that there was some histologic improvement here. And bariatric surgery, probably adequate for patients that have a BMI of more than 40, that failed diet and exercise with or without drug therapy. I think most of the patients with BMI of 40 failed everything. So, all patients that have a BMI of over 35 that have obesity-related comorbidities, such as hypertension, impaired glucose tolerance test, diabetes, dyslipidemia, or sleep apnea. And be careful with the patients that have NASH cirrhosis. Frequently we see patients that had cirrhosis, they never underwent surveillance of hepatocellular carcinoma. So patients that have NASH cirrhosis, ultrasound, and alpha-fetoprotein every 6 months at least. And to wrap up the take-home message, NAFLD, significant public health problem related to the metabolic syndrome. It's already part of it. We need a better understanding of the pathophysiology of NASH. And more than that, we need good prospective randomized long-term controlled trials with histologic follow-up to assess current and new therapies. Thank you very much for your attention.
You said this is common in the 4th and the 5th decade. What about in the adolescent?
I didn't mention that, but right now the fatty liver or NASH has become an epidemic in the pediatric population. We are seeing 18-year-olds with cirrhosis due to NASH, and it is now a big problem all over.
So you mentioned that treat hyperlipidemia. What if the patient is not showing any hyperlipidemia but does have the fatty liver, younger patients?
Younger patients without hyperlipidemia, I would not give medication for hyperlipidemia.
How about gemfibrozil? You mentioned, but you did not show any study of gemfibrozil for patient that has, increased triglyceride, but no.
I didn't study a lot of studies because we would be here probably until 12 midnight. But there are studies with gemfibrozil. The quality of the studies are not very good. There was some improvement of the liver test. There was no histologic follow-up. But there are studies with gemfibrozil.
So you were saying if you have elevated liver enzymes with fatty liver, it's okay to start a statin, not for fatty liver, but for cardiovascular protection?
Yes.
And what, if you're looking at those liver, do you have to prove fatty liver before you can?
Yeah, just make sure that they are from fatty liver and not from something else.
So if you have someone 9 years old with a fatty liver with clear weight gain edema, you're not going to give them metformin, you're going to make diet changes and exercise, but how do you, their family's a vegan family, so everything's carb for them. Do you have any suggestion on what you can do with that? If you're trying to help them lose weight, but they have so much of that insulin resistance, what can you do when they're straight carb eaters?
I didn't hear very well the question.
What can you do with a family that's all vegan, so they don't eat I don't know which it is, but they don't eat the cheese or eggs or dairy at all. But she's 9, she has such a fatty liver. She has all of the edema, she's a mess. But how do you help change that diet in such a child that's insulin resistant if they don't want anything in their family that's going to have any animal product at all?
Well, I think, diet change is, the patient needs to have a little bit character and realize that they need to change it. I think everything is a habit. We see patients that have cirrhosis, we tell them, eat without salt. And they say, oh my God, everything tastes horrible. But sometimes we do the liver transplant and then we tell them, now you can eat with salt. Doctor, I cannot stand salt. I just like it without salt. So I think everything is a habit and you just have to adopt it.
Thank you, Doctor.
You're welcome.
Okay.